অন করে দাও, অন করে।
হ্যালো, ক্লাস কখন শুরু হবে? হ্যালো। হ্যালো, ক্লাস কি শুরু হয়েছে? কোনো কথা শোনা যাচ্ছে না। হ্যালো।
Hello.
হ্যাঁ,
We are not also listening to anything. Possibly teacher has not come.
থ্যাংক ইউ। PC ma'am will take the class today, na?
Yeah, please again.
PC ma'am, Pooja ma'am will take the class today.
Name, I do not, actually, I do not know the name. I have not that information with me.
So when will the class will be started?
It is expected at 11 a.m.
11 already has passed.
But that we cannot say anything. Teacher will come and he will take the class. What we can do?
It's 11:15.
Yeah, at least no, 12, 13 minutes already expired. But maybe there is some trouble with them. Please wait. Thank you.
Is there anybody from RC Kolkata? RC Kolkata can communicate, can say the right thing, whether the teacher is available or not. Otherwise, we all will be waiting.
A teacher will be at his or her home, like us. He is also in the home like us. So there is no difficulties for this lockdown, etc.
No.
That's
RC
right, huh?
Kolkata.
RC Kolkata has organized this. They have organized, but the teacher will be in his or her home.
I know that teacher ma'am will be at her home. She will be
Uh-huh.
taking the class from her home, but RC Kolkata can contact the teacher.
That is, there is some official dealings, I mean, relationship with teacher and the RC Kolkata. We have to wait, or we can call RC Kolkata also personally. Why the class is not being attended by anybody? Is the class has been cancelled? We can ask that question.
Hello? Yeah, can you hear me?
Yes, ma'am. Yes.
Yeah, okay. There was some technical problem. Actually, I got the previous day, like the next class mail, okay, on the 11th. 11th, we have a class again from 11 o'clock. So that is what the problem was. But anyways, now it's okay. So all the clinical students are there for the second year.
Yes, we are all from Clayton background.
Yeah, okay. So we
Yeah,
have,
ma'am, second year, all second year.
yes, okay. So can you just please mute yourselves? I request all of you to mute yourselves. Otherwise, it's a problem. Yeah. Okay. So we had already started with the MPC 11 last day. Yes. What someone is speaking? Yeah. What do you want to say? Yeah. Please see if you have any queries. I think 10 minutes before the class gets done, we will take it. So now please don't unmute and speak because it's very difficult, right? Okay. So last day we started with MPC 11 and we were doing the block 1, and we have already done the 3 units, which was an introduction to the abnormal psychology, and then we did the different types of like the why, what is abnormality, and the models I discussed, and then I also did the causes, that is the different uh, factors leading to the psychopathology, which is also known as the developmental pathogenesis, and then we also discuss a little bit about the classification. So here we are left with only one unit of the block 1, which is the childhood disorders, I think. But today we will not start with that. We will straight away go to the block 2. Okay, so book 2, which we are going to do, and this one, the childhood mental disorders, we can come back to it later, because why, this is one entire stretch of disorders which is related to anxiety. So I want to do that first, okay, so that you can remember it very well. So here what you have in your block 2 are many disorders, okay, many. So it starts with phobia, okay, you have phobia, you have GAD, you have OCD, then what you have is you have a PTSD, which is the post traumatic stress disorder, PTSD, and then you have the somatoform, okay, somatoform and dissociative. So it's a lot of disorders. So let's see how much we will do all, okay, today we will cover all, but it requires a lot of study on your part as well. And apart from the books which you have, the IGNOU study material, that is definitely good enough. But still, I would ask you to refer to certain abnormal psychology books as well. And that is, one is the, you can just take down the names if you want. That is the textbook of abnormal psychology, which is also known just like abnormal psychology. You can get the 13th edition. Right now, the 16th edition is available, and the author is Carson, Carson, Carson Butcher, Butcher, Carson Butcher, Mineka, Mineka, Mineka. Okay, so I can just type the names in the chat box. You don't have to write it now. So there are two, three books. Then another book is, you can, it's very easy to remember. Oxford Book of Psychiatry. Okay, Oxford Book of Psychiatry. That is also a good book. I think certain PDF versions are also available. You can please check it. And all these books, any one is also good enough, because it is diseases, and after all, it is very similar in all the books. Just that the maybe the discussion of the case histories will be a bit different. So that is, apart from one, your IGNOU study material, you can refer to any one of the books, and that will be good enough for you for your assignments as well as for your exams. So we start with the anxiety disorder today, okay, which is block 2. What do you understand by anxiety? Anxiety is a kind of apprehension, the worry which we have, okay, and also it includes fear, fear for of something. What it is, that we don't know, but it is something like which is making us a bit uncomfortable. Okay, and that is the fear which we have, and we want to get rid of that, but we are very helpless. Okay, we are very helpless, but we are very clear that something is wrong with us. And that is the reason this entire anxiety disorder chunk falls in the neurosis and not in psychosis. So, neurosis, that tells you that this is very much the insight is present. Okay, the person who is having that particular disorder, that person knows that something is wrong with me, but I am helpless. The person is very much dysfunctional, that he realizes. The person is very depressed, that he realizes. But depression here is as a symptom, it's not the disorder. Had it been it was the disorder, it will go to the mood disorders, which is definitely psychosis, not neurosis. Okay, the person is depressed. Why? Because he is not being able to carry on with the so-called daily chores of life and the functioning which he was into, in terms of interpersonal functioning, in terms of social relations with others, and also the occupational functioning. So all these are getting disrupted because of something which he knows he has, but he is again very helpless to get rid of it. And that is the reason this is neurosis. And anxiety disorder is related to the unreasonable worry, tension, apprehension, or fear that the person has. Okay. Sometimes the objects are very clearly understood, that okay, I am fearful of this object. Suppose I am fearful of spiders. Am I clear? Or I am very scared of people. So are you having a social phobia? So these we will discuss in detail, but this is the introduction. Now anxiety, the word, it can, you can just date it back to times of Sigmund Freud also. Okay, because he said that we have three types of anxiety. One is the moral anxiety, the real anxiety, and the neurotic anxiety. So when we speak about the neurotic anxiety, it is because of the id. And I'm sure that you have heard about, because you already have done MPC 002 on personality, or three, 2 or 3. I think 3 is personality, you're done in first year. And that is on Freud, the theories of personality. There you have heard about id, ego, superego. So the id, which is driven by the pleasure principle, whenever it has anxiety, that is called the neurotic anxiety. But when we have the anxiety which is because of the superego, superego is like the policeman inside. Okay, so that superego anxiety, it is known as the moral anxiety. because it is by deciding the moral, ethical, or moral standards. It is telling you that what is correct, this you should approach, or this is not correct, you should avoid. And now something which is we call the ego, which is a mediator of the then the superego. When anxiety is faced by the ego, that is known as a real anxiety or a realistic anxiety. Okay, so that is still manageable, that we can deal with certain types of like mechanisms which are there. But the thing is, these three types of anxieties are very important, which keeps on happening to all of us, right, at different times. But we manage with our own coping abilities which are there. But when there are people who are not being able to manage these anxieties, especially I'm saying especially the two anxieties being neurotic as well as the moral. Okay, so neurotic anxiety as well as the moral anxiety, then it becomes extremely difficult for the person, and he might shift into that thin line of abnormality. And now that is the thing. I think I had discussed this last class, that see, whatever the symptoms the patient reports, the two words were signs and symptoms. Signs are something which the psychologist, the psychiatrist observes in the so-called patient or the client, but the symptoms are reported by the patient or the client, right? Now, whenever the symptoms are coming, it is something very much disturbing. This is not something which is very much acceptable to the client. It is not, right? Because of these symptoms, he is not being able to perform the way he or she was. That is the pre-morbid personality. Before the development of the illness, he or she was a different kind of person. So now she is not being able to carry on with whatever was there before. And that is the reason she or he is disturbed, right? So that is the reason the person reports these anxieties. So, or rather, the symptoms. When these symptoms are, reported, it is very much evident, or it is becomes a very crucial thing for a psychologist or a psychiatrist, that whether that anxiety is neurotic or that anxiety is a moralistic anxiety. Are there feelings of guilt involved in it? Okay, guilt. That is very important. And then, why is this important? First and foremost, yes, for diagnosis, I have to know that what is that particular or exact problem that the person is suffering from. And second is, I have to plan the therapy. I have to decide on the interventions which will be the best suited or optimum for the client. Am I clear? So this is the thing. This is the overall picture. So here, anxiety disorders are, we can refer it to as abnormal states in which the most striking feature are the mental, okay, mental as well as physical symptoms. And these mental and physical symptoms are the indicators, are the signs which you need to look in the particular patient. And these anxiety disorders may be divided into, first is phobia, then we have the generalized anxiety disorder, commonly referred to as GAD. Then you have the obsessive compulsive disorder, which refers to as OCD. Okay. Then you have the PTSD, post traumatic stress disorder, with a panic attack. And panic attack can be done separately also, but that is not included in your syllabus, I've seen. But we will discuss a very briefly, because agoraphobia sometimes is coupled with a panic attack and sometimes it is without a panic attack. So these are the disorders which comes generally under anxiety disorder. Apart from that, there is a different chunk of disorders which are under neurosis, and that is the somatoform and the dissociative, which you have in your syllabus. The somatoform and the dissociative. So this entire thing is your block 2. Now, as I was telling you that there are certain physical and certain mental pictures of anxiety. So we can just, discuss, or we should know that what are those. When we speak about the physical picture, it is what? It is a tension, the stress level. So all these are very much common features when it comes to physical features. Okay, tension and stress level. But when it comes to the psychological ones, then it will be irritation, then it will be fear, then it will be apprehension, then it will be unreasonable worry, and certain times the we will come to this again because it's very important, that there is a kind of a syndrome, we can say, or a symptom, that is flight or fight. Am I going to escape from that situation? Okay, that is flight. Or am I going to face it? And definitely facing is more healthy than escaping, because we cannot keep on just escaping situations in life. We have to confront them as well. So fight or a flight. Fight is facing it, and flight is totally escaping away from it. So these are the things which happens in the physical as well as the mental symptoms of anxiety. Now we will do one disorder at a time, right? So first let us start with the GAD, generalized anxiety disorder. So when we come to the GAD, generalized anxiety disorder, what is very important for us to know is, in this particular disorder, the reasons for anxiety is not related to one particular thing, but it is spread out. Okay, it's a widespread thing, and because it's a widespread thing, that is the reason it is known as GAD, and that is the reason that this name is attached, that is generalized. So the symptoms of GAD are persistent, and it is not restricted to, or markedly increased in any particular set of circumstances. So it can be that all the symptoms of anxiety can occur in GAD, and here the main characteristic feature of GAD is a persistent worry. Okay, so excessive worry under most circumstances, and worrying about practically anything. Anything. That is why it is generalized. It is worrying about anything. And this worry, it shouldn't be it's 1 week or 1 month, no. For it should be at least for 6 months. 6 months it should stay. And it is very difficult to control this worry. And at least three of the following symptoms should be there. And what are these three of the following symptoms? First, it is restlessness. Okay, any three. I'm telling you more, but it can be any three. Restlessness, easy fatigue, you're getting easily fatigued, tired. Okay, irritability, muscle tension, and sleep disturbance. There are more added to this, but this is a DSM-4 checklist. So out of these, at least three should be there. Okay, the person, it should be restless, fatigue, irritability, muscle tension, sleep disturbance. So out of these four, at least three should be very much there. And definitely we cannot forget difficulty in controlling the worry. Okay, so the symptoms should at least last for 6 months in order to label the person as having GAD. Now, suppose I'm telling you here, suppose the relatives and friends of people with this disorder sometimes accuse them of, like always worrying for everything in life and looking for things to worry about. And they are saying that এই তো সব সময় চিন্তাই করে যায়, and they look for excuses to worry about. And therefore, rather than being happy, they are just always worrying. That this is the report of the family and the friends. Okay, so most of such accusations are very unfair, because people with this disorder hardly are able to feel happy. Am I clear? It is not that ki ora jor kore korche. It is not like jor kore korche, but it is a disorder, and that is why it's just happening. So this is what is there, and they feel that they are in a constant struggle, always threatened. They feel, the GAD people, they feel they're very much they're in a struggle which is day in day out, and they are very threatened, and they want to defend themselves, but they are just not being able to escape their pain. Am I clear? They're not being able to escape their pain. So I will just come to again certain symptoms of GAD. First is worry and apprehension. Okay, widespread worry it is there, and sometimes there can be a panic attack even. Okay, then psychological arousal. Now what is here? Here you will have poor concentration, Then they are irritable, they are very sensitive to noise, they're not being able to take slightest of noise also. There is muscle tension, okay, muscle tension, that they have a constant headache. Then there is trembling, okay, there is the inability for the person to relax properly. There is a ache in the shoulder and the back, okay, neck pain, all these are there. Then there is an autonomic hyperactivity. What is it about? If there is sweating, excessive sweating, then there is palpitations, there is dry mouth, okay, there is dizziness, and there is some kind of a gastric discomfort. So you can see there are so many symptoms, right? Then there is sleep disturbances, which is very obvious. If you are very much, like always irritable, anxious, worrying, scared, how will you get a good sleep? So sleep disturbance is very much there, okay, which we refer to as insomnia. They also might be having unpleasant dreams, okay. Then there is this thing, hyperventilation. Hyperventilation is like a feeling of, which leads to a dizziness, okay, and there is a shortness of breath. So these are the things. Apart from that, I told you that depression is something very common as a symptom, because whenever you're having these kind of problems, you are not being able to lead the so-called normal life which you had been living, you know. Therefore, for that reason only you will be depressed. So these are the symptoms. So now you know what is GAD and what is the clinical picture or the symptoms for GAD. Now we will be discussing the causes of GAD. Okay, why, what leads to GAD or what happens? Then, can we stop that? Okay, let's see. First is the stressful events in life. We all encounter some of the other stressful events. Right now we are all encountering a stressful event in life, which is a global pandemic, and we have never faced, and we don't know how to cope with it. And I'm very much certain about one thing, I'm very sure about one thing, that now we are living with it for the past 6 months or so, and every day I think we have been learning new coping strategies, which way ahead in March, okay, when the Janta curfew started on the 20th or the 22nd of March, then we were not that well prepared like the way we are right now today on the 7th of September. Am I clear? But these people, they are not, they are very vulnerable. So with little bit of stresses in their life, they are having problems. It can, what are the different stressful events? It can be a bereavement in the family, there can be a loss of job, you know, and then there can be certain other things, there can be fight in the family. So these type, or maybe losing a pet, anything which gives you stress, that becomes very magnified for them, okay, and they're not being able to deal with it. Then, are there any genetic causes? Yes, there can be genetic causes. It has been very well reported in the family and the twin studies, okay. So in the family studies, it is said that the among the very first degree relatives of probans with GAD, they are more probable or vulnerable to get that same disorder, like the those who are not, or maybe the first degree or the second degree relatives, okay. So the more you are closer to your family, the more genetically you are tied up, the more vulnerable you are to develop the disorder. Then twin studies, in the twin studies it is said that we have two types of twins, right? One is the monozygotic and the dizygotic. There is higher concordance rate, that is higher rate for developing the disorder of, and for this anxiety disorder, between the monozygotic twins, okay, because of the sharing of the same zygote. So there are genetic issues also. Then what about the early experiences we face in life? Early experiences, which are the early adverse experiences, that I would put it rather like that, that there is something unfortunate which has happened, okay, and you're disturbed because of that, and it can also be a very rough childhood, okay, where your parenting was not fine, the child rearing was not fine. So all these things they add up to an early adverse experiences. Then I would just quote one study here. There was a study done by Brown and Harris. Okay. And what they did was they studied the relation between the adverse experience in childhood and the anxiety disorders which you find in adult life. Okay. And they did the study on working women. Okay, around 400 working women, and adverse early experience were assessed from the patient's account of the parental indifference. I told you this is something very, very important. You will keep on, bumping into this particular point for so many disorders. That is whether the child is having a disturbed childhood or not. Am I clear? So this disturbed childhood is very, very significant, you know, in actually ruling out the fact that whether you will be having a mental discomfort or not. So here again we are seeing that if there is any parental indifference, the child rearing practices style were very authoritarian in nature. Okay, and there was, we cannot forget one thing, that there was physical or sexual abuse, physical or sexual abuse. So women, who are having these kind of early adversaries had increased risks of for developing the GAD. Okay, very high risk. Then this is what the study confirmed. Then we come, so I have discussed already about stressful events. That was the first causal factor. The causal factor is also known as etiology. Then second one was genetic causes. Genetic causes, if we have done the twin studies and the family studies. Then we discuss about the early experiences and a study by Brown Harris. Now we are coming to another point, which is psychoanalytic theory. Somehow little bit I have already discussed in my introduction to anxiety about this. Here, psychoanalytic theory, as definitely put forward by Sigmund Freud, he says that anxiety arises from intra-psychic conflict. I would just tell all of you to note this. This is very important. As for Freud, he is saying anxiety is arising from intra-psychic conflict. Now, if you ask me that what do you understand? What is intra-psychic conflict? Okay. Now, conflict is what? There's a clash, you know, there is clash, there are people who are fighting over this, and intra-psychic. I told you that Freud has given the three levels of mind as id, ego, superego, and id, ego, superego are all going by different types of principles which does not match. Id is driven by pleasure principle, ego is driven by reality principle, whereas superego is driven by morality principle. So none of them are same. So these three constantly they fight. Maximum fight is between the superego and the id because it is totally opposite in nature. So whenever these clashes are occurring, Freud has termed this as intra-psychic conflict. Okay, so he says that anxiety is a result of the intra-psychic conflict, and it arises when the ego is overwhelmed by excitation from any of the three sources. Here I told you that CE is something which is present since birth. Okay, and superego generally develops when your moral development occurs. If you do not understand that what is right and what is wrong, if you are not having the development of the emotion called guilt, then the superego is not yet, developed properly. Now here what happens is, when this thing is there, Freud says that very important for him to understand is the ego. Okay, ego is a very important factor for to be understood basically. So how the ego is getting overwhelmed or excited by factors like, number one, the outside world, number two, the instinctual level of the id, which is love, which is sexuality, which is anger, okay, and also the moral part, which is the super ego. So how the id is basically getting attacked by these things, it is very important. And it has been seen that whenever the ego is attacked by these factors, it leads to GAD. Am I clear? It leads to GAD. So anxiety is experienced directly, unmodified by the defense mechanisms. So here we know that anxiety is experienced, right? Now, defense mechanism. Now, if you don't know what is defense mechanism are certain unconscious mental mechanisms which Freud says that we are using in order to deal with the intrapsychic conflict. But these are not healthy, and exaggerated use of defense mechanisms leads to the development of mental disorder. And that is the reason he says here that this is a cause. So the theory proposes that in GAD, the ego is readily overwhelmed because it has been weakened by a developmental failure in in which stage of life? Definitely you can guess so. Yes, it is childhood. So, in childhood only, there has been a developmental failure of the ego, and that is what it leads to a lot of problems. And then we come to the separation and loss. Separation and loss feeling from the parents. If I have a void, if I have a separation anxiety, it is something very much that it will lead to GAD. Okay, it can be also at times leading to certain adverse feelings you might have towards your father, like you might have a castration anxiety, you know, you might feel very much threatened by the presence of your father. This is especially for the son I'm talking about. Okay, and all this surmounts to money, this is a failure basically. The it is threatening to the ego, it is threatening to the self. And whenever your self esteem gets little bit disturbed, then there are questions about your self worth. What is my value? Am I fine? Am I worth it? I don't think I'm worth. And then this spiral of anxiety it starts. Okay, there are other causes as well, like the cognitive or behavioral theories. They also have put forth their causes. What does the behavioristic school say? They say that GAD arises when there is an inherited predisposition to excessive responsiveness to the autonomic nervous system. So the ANS is there. If there is too much of responsiveness which is towards the ANS, then it sometimes gets very much, the person gets hyper. For example, see, stress is a parcel of our life, part and parcel of our life, right? You can say, yes, we were not prepared for a stress like a COVID-19. I agree to it, but then you never know, from 2021 again we have different type of stresses coming our way. We have to accept it. So it is something, and yes, it is difficult. Definitely it is difficult, and but still we need to start preparing and we need to build up the coping strategies which we have. Now they are saying, the learning theories, they say that if you're very much hyper towards this ANS, then it's a problem. Ajke, this everyone is facing, but there can be one or two of us who are like, oh my god, what will happen? Oh my god, I will die. So these are the people who are more vulnerable to develop this disorder. Then the cognitive theory, they says that GAD is arise because of a tendency to worry unproductively. When this worry of yours is so unproductive, okay, about problems that focus attention, and you are not focusing attention everywhere, rather you are just focusing your attention on the negativity of towards life. So, see, we have both the negative as positive balances in our life, right? And if we do not focus on the positivity and just see the negativity very in a very big way, then definitely it's going to affect. And every time you'll be negative, so you'll be threatened. And the last cause is, আমি কিন্তু এই কজটা এত ডিটেলে কেন করাচ্ছি, বিকজ যখন we will do phobia, we will do OCD, অনেকটা একই রকম causes ও হতে পারে, studies will change. Okay, personality traits, this is another cause. There are people who are very vulnerable. Those are people who are having that anxious personality. I told you, আজকে ধরো I'm waiting at the bus stop and this particular bus is not coming. A person is like, okay, ঠিক আছে, একটা মানুষ এরকম হতে পারে, আসছে না বাস, let me try the metro. আরেকটা মানুষ is like, oh my god, বাসটা আসছে না, এবার what will happen? I'll get late for office. I will do this. I will do that. And then entire thing is in a whirlpool of worry, and then the stress. Okay, so personality factor is very important. Whether the person is neurotic, having certain traits of neuroticism, এটাও তো important. তারপর GAD occurs in people with anxious avoidant personality disorder. Let me tell you, there are some disorders, like I had mentioned you about the multi-axial assessment. Axis 2 has all the mental retardation and all the types of personality disorders. তার মধ্যে one of them, যেরকম borderline personality disorder আছে, তারপরে avoidant personality, এই avoidant personality disorder যেটা anxious avoidant, that if you have, then you're a little bit open to or more vulnerable to develop the GAD. Okay, so I am done with the GAD. And the treatment, if you say, definitely counseling is very important. Relaxation therapy is important. Okay, the person should practice certain types of meditation, yoga, breathing exercises, very important. You should practice the breathing exercise. Then you should have a clear plan of certain things like a to-do list and all. Okay, so all that, then you need also a reassurance. That reassurance can be given by the counselor. Okay, then you can have relaxation training, যেটা হচ্ছে muscle relaxation, because muscles are very tensed. So this was relaxation therapy was given by Alan Jacobson. So we say Jacobson's PMRT, progressive muscular relaxation therapy. So this therapy is given where you are actually tensing your muscles, starting from the head to the toe, slowly, one by one, and then relaxing them. So when you do the entire body once, then you feel very, free, and you relax and you feel good about it. So that is their relaxation training. Then I told you about the this thing, the cognitive behavior therapy. Many a times, behavior therapy, there are a lot many strategies. Like the behavior therapy works wonders when there is phobia, okay, even OCD, that we can discuss it a little later. And finally, we cannot forget the pharmacotherapy. Pharmacotherapy includes the medication, because you need to prescribe some of the anti-anxiety drugs, anti-anxiolytic drugs, like you have this thing like like alprazolam, a slight, very minute milligram, like that. So anti-anxiolytic drugs are there, but definitely it will be very strictly given on basis of the prescription. Okay. And you can say that yes, sometimes family therapy is also required. Family therapy, certain management, that type is also required. Now we will do phobia. So GAD is done. What is phobia? Phobia is a fear. Okay, phobia is not anxiety, but phobia is fear. Fear which is definitely unreasonable in nature. Okay, phobia which you cannot explain. So it is very unreasonable. There is no logic attached to it. রাইট, লজিকটাই নেই। মানে কেন তুমি ভয় পাচ্ছ সেটা তোমাকে যদি কেউ এক্সপ্লেনও করে তুমি সেটাকে মানছো না। সো দ্যাট লজিক ইজ নট দেয়ার। So phobia is a persistent unreasonable fear of, it can be of a particular object, it can be of an activity, or it can be of a situation. So people with phobia become very fearful. If they even think about the object or situation, they dread, but they usually remain very uncomfortable. Mane, they are definitely uncomfortable because they are wanting to get out of the fear, but they are not being able to, right? And that is why they are in the disease state. And what happens is, like this fear is very intense and persistent. It is intense and persistent. It does not go very easily. যদি চলে যায় তাহলে তো আর ডিজিজ হবে না, তাই না? তো ওটা থেকে যায়, and you're trying to deal with it, but you're very helpless. You're not being able to deal. You're not being able to deal with. Acha, I am telling you something. Is there Anindita here? There's some Anindita student here in the class, or is she's not there? I don't know. I'm getting one call. Please don't call me up now. This will disturb the class. Okay. Now this is what is phobia. Okay, so there is a fear. The fear can be, it is very important because this is very much directly related to the types of phobia. Okay, the fear can be of a particular thing. If it is a particular thing, suppose it's snake, or it is blood, okay, or it is thunderstorm, or it is germs, okay, then it is basically which category? It is a specific phobia. Am I clear? Specific phobia. So specific phobia is, or we can, there are some other names for this also. Specific phobia is also known as situational phobia, and it is also known as simple phobia. Okay, simple, situational, specific. এই তিনটে কিন্তু it is the same thing. So when my fear is regarding a one particular object, like suppose when it is water, আর প্রত্যেকটার কিন্তু নাম আছে. If it is water, and many of you are familiar with these names, it is known as hydrophobia. Okay, it is hydrophobia. When it is, suppose it is air, it is known as aerophobia. When it is germs, it is known as spermophobia. Okay, when it is about heights, there are many people who cannot dive swimming pool এ ওপর থেকে যখন ওটা করতে পারে না, so that is, if you have that fear of heights, it is known as acrophobia. Okay, so eram type there are many. Blood টা বললাম, that is hematophobia. Strangers, xenophobia. So these are the different types. সেখানে কিন্তু you are just scared in that particular situation. ঠিক আছে, তোমার performance will decrease, you will be very highly embarrassed. Okay, and then what is happening, you are scared and you will never be able to perform anything. Okay, so that is the specific phobia, which we will do little in detail. Second one is the social phobia. Now what is the social phobia? Social phobia is a fear of social or performance situation, okay, in which embarrassment may occur. Like for example, I am scared to go out, I am scared of the social gatherings or social situations. Now the reason why am I scared? Because of one fact, and that is the fear of evaluation. Okay, because of the fear of evaluation, I am not being, or I am avoiding the social gatherings. Am I clear? So this is what happens in social phobia, and that is why I might be very embarrassed to encounter people. And third one is agoraphobia. Agoraphobia means fear of venturing out to open places, or which can also be public places. ঠিক আছে, especially when one person is alone. Now you will say, then what is the, like, difference between social and agoraphobia? Social phobia, there is the fear of evaluation, which is very pertinent and strong. But when it comes to agoraphobia, it is not the fear of evaluation. It is just that you feel very scared because you are feeling that you are going away from a safe and secure environment. Okay, you're very going very far, and then you don't know how to come back, and you will not be able to come back. এই জন্যই ভয়টা, you will not be able to come back, so you don't want to go. And this can be coupled with a panic attack. Okay, it can be in conjunction with the experience of panic attacks. And what are panic attacks? Panic attacks are like unpredictable attacks of terror. Okay, unpredictable, you just don't know what is going to happen, you're so scared. Am I clear? You're so scared and you just don't know what is going to happen to you, and you feel that you will die. So that is a panic attack. And there are attacks of terror, Okay, these are attacks of terror, as I told you. And many a times an agoraphobia can also be without a panic attack. So these are the types of phobia. So I have told you already about the specific phobia, which is related to যে এতগুলো example দিলাম, claustrophobia, hematophobia, pyrophobia, xenophobia, এগুলো সব specific, অন্য জায়গায় কিন্তু the person is fine. Okay, so this recognition of that fear is very excessive and it is unreasonable, and it is actually, it causes distress or significant impairment in that particular area only. Am I clear? Now comes social phobia. When we speak about social phobia, the checklist of DSM says that the anxiety usually produced by exposure to the social situation, and recognition of that fear is also excessive and unreasonable, and the avoidance of that particular situation, social situation, and this causes significant distress and impairment. And why is the person fearing the social situation? Because of the performance anxiety. There is an involving an exposure to unfamiliar people or possible scrutiny by others. Please remember this word. The person is scaring the evaluation. The person is getting scared of the scrutiny which may be done by others to him or her. Okay. And this concern is about humiliating or embarrassing oneself. Okay, are you clear? So this is social phobia. So you know what is specific phobia, you know what is social phobia. Now I will tell you about once about maybe agoraphobia, that also I've told you, that is the fear of open places, and I am scared because I am not being able to come back. Now, what are the causes of phobia, right? There will be little overlapping because it's similar. Generally anxiety disorder cause. তো এখানে first day learning টা আমি বলবো. Do you think that fears are learned? The answer is yes, it can be learned. Not every time, but it can be learned. For example, there is a classical conditioning, right? You know, learning a classical conditioning and a theory which was given by Ivan Pavlov, right? So here the classical conditioning happens when there is a linking of the conditioned stimulus with the unconditional stimulus. Okay, conditioned and unconditioned stimulus, the pairing up happens, and what happens? The unconditioned stimulus starts behaving like the condition and starts giving the same type of response. So what happens? Suppose common way of acquiring fear reaction to object or situation that are not really dangerous. Here what happened? Just the two events got paired up, and the actually one dangerous situation থেকে তোমার non dangerous situation টা link হয়ে গেছে, আর non dangerous situation টাকে এখন তুমি dangerous হিসেবে label করছো. Am I clear? So this is what happening. And if one even triggers a fear response, the other may also trigger a fear response, which becomes very automatic. একটা যদি fear response trigger করে আরেকটাও কিন্তু automatically the fear response is triggered. And there are many studies you can read when you read the books which makes it very clear. আরেকটা হচ্ছে modeling. Modeling এর মধ্যে observation and imitation টা involved. অবজারভেশন এন্ড ইমিটেশন, আজকে আমি একটা জিনিস ভয় পেতাম না, বাট আমি দেখছি একটা অন্য মানুষ একটা জিনিসকে ভয় পাচ্ছে, সো সিইং দ্যাট পার্টিকুলার থিং আই ক্যান অ্যাকচুয়ালি even learn from that particular person that okay, like this the person is getting scared of the lizard, so seeing a lizard you should actually get scared like this. Have you understood? So that can be an observational learning. Another or modeling. Another observation, like example, I think we have all seen that movie, no, Baby's Day Out. We have seen how the child actually had observed something in a storybook, but that how he started applying in real life. So exactly here also, if we are observing something, we try to apply that. Okay, and the similar way we start getting scared here because it is fear, the scare thing. Like I'll give you one example here about Albert Bandura. He had done a study with rabbits. Okay, and then what happened? There was one child who was playing with rabbit, and the child was not scared. Suddenly there was a very loud noise and the child got very, very scared. And after that particular occasion or after that day, whenever the child plays with something white and furry, the child gets scared. It can be a cotton wool also, a ball of cotton wool, but it's not a rabbit. But just that the association has been so that anything white and furry makes him scared. Okay, so this can be the behavioral exploration for phobia. Then we come to the fact that what can be the other causes of phobia. There can also be the biological perspective. Okay, biological perspective. And to understand this, we have to know about certain types of like the makeup of the brain. You know about the amygdala, which is very much responsible for controlling the emotion, right? Amygdala. Then there are many neurotransmitters also, which are like the dopamine, the norepinephrine, the serotonin, which all play their role. Anything which is functioning is not very okay. Either there is a hyper functioning which is more, or it is a hypo functioning which is less. That leads to certain disturbances in the behavior of the people. I will just give you one example. Like many of the antidepressant drugs, okay, change the activity of the norepinephrine that carry messages from the neuron in the brain. Okay. Now, if this drug also, the drug also eliminated during panic attacks, the panic attack might be caused in the first place by abnormal norepinephrine activity. So basically, if there is any abnormal non-epinephrine activity, there can be it can lead to panic attacks also, and finally it can be leading to the this thing, the anxiety disorder. Then comes another thing, which is several studies have also show produced this evidence that norepinephrine activities is indeed irregular in people who suffer from panic attack. Okay, so the you have to check the level of the norepinephrine. Okay, norepinephrine, and this can be checked in one particular brain area which is actually rich in norepinephrine, and that is locus ceruleus. But অনেক সময় না, these many times these type of experiments are done on animals like monkeys. এটা monkeys এর উপর করা হয়েছে, and then there is one particular very big question mark that how to handle this, how to manage. Because how can we always say the comparative psychology, how can we link the animal, whatever findings you have got from on the animal or from the animal to the human beings? Am I clear? But then there are times which is ethically not possible to actually do the same type of research as we have done on animal or the human beings. Then so we have to rely on that only. Am I clear? So there can be this norepinephrine activity. Then from the cognitive point of view, yes, there can be certain, like presence of automatic negative thoughts. As I told you, even for GAD, if we are mainly here, the people are very anxiety sensitive. That goes without saying. The high degree of anxiety sensitivity is there, and they focus on the bodily sensations. Okay, like they are and they interpret that. They're very much kind of sensitive, highly sensitive towards their bodily changes, and that only they label as anxiety. Like for example, if they're over breathing, if they're hyperventilating. Okay, so apparently the abnormal breathing makes them think that they are in danger. Okay, and they also feel that they might even suffocate. They might suffocate and they might die. Okay, so these things are happening. So other physical sensations that can be misinterpreted, including excitement. এটা তো জেনারেলিও হতে পারে। আজকে একটা মানুষ ধরো, the person can be excited, or the person can actually hyperbreathe, or it can be there is a discomfort in the abdomen. There is sometimes a lot of anger. These can be generally there, but these people are so very hyper, they are so anxiety sensitive that the moment all these happens, they label them as anxiety. They label them as, some kind of things which are to be noticed very properly, or treatment is required. So sometimes there is a palpitation in the heart. So sometimes this misinterprets, when they misinterpret them as a sign of heart attack or even a panic attack. Okay, so this is the cognitive explanation or state of mind. So yes, there are certain cognitive errors which are there. Okay, cognitive errors which are working, and which says that no, this is nothing but you are very scared, this is going to do something bad to you. It is important, it is telling you that this something bad is going to happen. And then when we finally come to the psychoanalytic theories, it says that the internal source of anxiety, the external stimulus, but to an internal source. There is some internal source of anxiety, and that can be maybe the use of too much of defense mechanisms. Like I told you, it can be repression, it can be, there are different types. Huh? Please study all this very thoroughly. There is displacement. So these, if a person is too much using these kind of defense mechanisms, then there is a thing that it will lead to phobia. And finally, I will speak about one thing, which is the cerebral localization. And here we all have heard about the PET scan, which is the positron emission tomography, or the CT scan, computed tomography. So when these scans are happening, okay, that imaging studies are happening, it tells you that certain types of abnormality is existing in your brain function. That is for very sure, and those pictures are indicative of that. So the PET has been used to study changes in the blood flow when people with a specific phobia are exposed to a feared stimulus. So at those times, these people have actually been studied like this, and they have tried to find out that what are the abnormalities, what are the different, and generally all this, the picture shows that there is a difference in the coloration. Okay, and this is how, then maybe what type of medicines might help. Okay, and if there is any kind of hyperactivity in certain areas, and with certain injections or applying whatever medicine, if it can actually lessen the hyperactivity, then we can deal with this. So এটা ট্রিটমেন্টে চলে আসলো. So treatment is similar only, I told you, but phobiate very important treatment is the behavior therapy. Behavior therapy is very important, because when it comes to causes like observational learning and all, then behavior therapy, at times family therapy, all these becomes very crucial. And we can definitely not forget the relaxation, the exercises, yoga, meditation, that is there, and certain types of drugs. Okay, drugs. Like you have another neurotransmitter, the SSRI, that is the serotonin. Then the SSRI is given. The serotonin reuptake inhibitors are often the first choice, and there are certain medicines like, and just one, I'll tell you one name. Like for example, fluvoxamine. Fluvoxamine is prescribed, or you have the paroxetine. All these are prescribed so that there can be reduction in the abnormal activities. Okay, now two disorders are done. The major ones: phobia, which is very huge basically, because phobia is divided into three, as I told you: simple, social, and agoraphobia, with and without panic attack. Then we have done GAD. Now we will do something again which is very important, which is OCD, obsessive compulsive disorders. Okay, now what is obsession and what is compulsion? Now onwards, I will be a little faster, because you have already understood that more or less the etiology is similar. You know, the etiology when it comes. Just 1 second, I'll just have water. In terms of the etiology, it is similar only, because see, it will have a learning theory, it will have a cognitive theory, it will have a psychoanalytic theory, it will be having a genetic cause, and it will be related to personality factors, Okay, or it can be just a stressor whichever you are kind of facing in life. So এই জায়গাটা points টা কিন্তু similar. Okay, but yes, the explanation will be different and the case histories or the case studies will be different. Now we come to OCD. This is again very very interesting. The obsession is different and compulsion is different. Obsession is at the thought level, whereas when we speak about the compulsion is at a behavioral level. Okay, so the obsession is at the thought level and the compulsion is at the behavioral level. So when we speak about obsession, okay, it can be obsessive thoughts, it can be obsessive images which are coming, okay, obsessive ruminations which are there. So what is, when this obsession is it's just a forceful thought basically, okay, of intrusive in nature, a forceful intrusive thought which is gushing inside our head. We want to control it, but we are totally helpless. We cannot control, and it is just forcefully entering our head. And this is like, you can just link it like when you have this thing, like when a flood is coming and there is a dam and even the dam is getting destroyed, everything is broken, and that water is actually forcefully entering. You're trying to stop it, but you're helpless. So this is something very important, and this is only what happens to the thought process. So obsessions are the persistent, the recurrent, disturbing thoughts, ideas, or impulses or images, okay, which is coming in the person's consciousness. Now, when we speak about compulsions, what are compulsions? Compulsions are working at a behavioral level. So when this obsession I want to stop, I am not being able to stop it because first and foremost I am scared to reveal it in our so-called daily life or in the public. I am scared to reveal my obsession. Why? The question is why? Because I think they are not socially acceptable. And if I reveal it, I might be further losing my place. I might be further evaluated and I will be thrown out from the social group. The person is not ready for that. So, but still the person wants to control. Now, how this controlling happens? The controlling happens through certain behavioral exercises, behavioral things which the person is into, and that he or she thinks which actually will help him to deal with the circumstances. Like for example, I'll tell you, suppose I have a guilt. What is the guilt? My obsessional thought is I want to kill my mother. Am I clear? I want to kill my mother because I hate her. Now, this is a guilt which is working in me. I know this is something very wrong, but it is a very strong tendency inside me. I am not being able to reveal it. Why? Because it is not a socially acceptable thing that I will kill my mother. So, what I do, there is some guilt working, but I cannot help with that guilt. So, I will engage myself in certain behavioral activities which is basically keeping me busy, number one, and which is trying to temporarily take me away from that obsessive thought. It is trying to take me temporarily away from the obsessive thought. Do you think that this is a correct way of dealing it? Definitely not. Okay, definitely not. This is not the correct way of dealing. But the person for that particular moment, the he or she says that, okay, fine, this is the only way I can be out of that particular thought. Okay. So, for example, the person can start washing hands. Washing hands, and that too, it is a compulsive washing hand. And that washing hand is for hours. It's not a 10 minutes thing or a 5 minutes thing or whatever. It is for hours. So that is the entire activity of washing hands is socially acceptable. But the duration for the activity which the person is engaged in, that is definitely not normal. That is abnormal. I'm keeping on washing my hands. But when I am washing my hand, I know that no one will scold me, no one will think something wrong of me. Why? Because washing hand is good, or it is a social phenomena. This is one. Second thing is that washing hands, the duration I am involved in washing my hand, basically that is helping me to stay away from the obsessive thought. So compulsions are repetitive and rigid behavior, okay, which are the mental acts that people feel that they must perform in order to prevent or reduce anxiety. So this is basically helping me to reduce the anxiety, but then this is not a healthy way. For example, suppose we might find ourselves filled with thoughts about an upcoming performance or an examination. Okay, and worrying that we forget to, like maybe we worry that হয়তো আমি স্টোভটাকে off করলাম না, the burner is still on, then I have not locked the door properly, then all these things can happen. Okay, and we may even feel better when we avoid stepping on maybe certain form of like আজকে যে ওই black and white mosaic যেটা আছে, I might step in all one of them. Might get involved in religious activities like praying. Basically compulsions গুলো অনেক রকম activity হয় না, compulsions টা ভীষণ, it is very much restricted. So there are certain types of compulsions which are there, which exist, and those are praying, counting, okay, checking, doubting. So these are the fixed compulsive behaviors which are there. So when you are in an obsession, you can have certain obsessional rituals, you can have obsessional images or impulses to perform certain acts which is usually of a violent or embarrassing kind. Okay, like for example, you might just feel like you want to injure your child, or you want to kill your mother, like I told you. Or you might have an obsessional slowness, and that obsessional slowness, it's like related to obsessional thoughts and rituals which lead to a slow performance. Okay, and you are doing it very very slowly. And it can be also perfectionism is also an obsession. Okay, I just need to be perfect, and I'm keeping on erasing, and I'm trying to draw a circle, but I feel that circle is not exactly the circle. Something is going wrong, and you keep on erasing to that particular extent, it might tear the paper. Am I clear? So all these things are happening. So, and whenever these happen, there is nothing that it gives you a very happy thing, and it makes you very happy, and you're enjoying it. It's not that. You will be depressed, you will be sad because you want to come out of the situation, but you're totally helpless. So now we will focus on the causes of OCD. Okay, what are the etiological factors? First, yes, genetics is there, and many studies have shown that OCD were found in 5 to 7% of parents of patients with OCD. So it is basically coming from the parents to the child. And we cannot forget the twin studies where they say the monozygotic twins have a higher concordance rate of developing that particular disorder. Then comes an evidence of the brain disorder. There is associations that OCD has noted that it will be when it recorded frequently, it was recorded frequently among patients who were affected with the encephalitis. Okay, and একটা প্যান্ডেমিক এপিডেমিক হয়েছিল in 1920s, তখন ওই এনসেফালাইটিসের সময় অনেক এনসেফালাইটিস হয়েছিল, আর ওই সময়টা অনেকটা ব্রেন ডিসঅর্ডার হয়ে গেল, ঠিক আছে, and then they were it was suggested that many people were having this obsessive compulsive like features. Okay, and then we come to the brain imaging studies that I told you, CT and the PET, and it has shown that there is structural brain abnormality, in the OCD patients, and the PET scan have confirmed. And what is the abnormality? The abnormality is the hyper functioning, the increased functioning, where The increased functioning is in the anterior cingulate gyrus. It is found in the orbitofrontal cortex. It is also found in the caudate nucleus. And there are certain parts of the thalamus. So basically all these are part of the forebrain. So certain parts of forebrain we find abnormal hyperfunctioning when the CT or PET scans are done, and that confirms OCD. Okay, then we have an abnormal serotonergic function. So this neurotransmitter called serotonin, that is abnormally functioning, and that might suggest the presence of OCD. Okay, so the 5-HT function might be abnormal in an OCD disorder. Okay, so the 5 hypothalamic যে pituitary axis আছে HP axis, ওখানে মানে the 5-HT function যেটা uptake inhibitors এর, that is abnormal in nature when it comes to the obsessive compulsive patients, and attempts has been to মানে there, you know, to assess this 5-HT function, and মানে doing with the help of both the neuroendocrine tests also and certain imaging studies. তো সেখানে একটু করে যদি কিছু করা যায়, certain drugs if it is helpful to reduce that abnormal functioning or hyperactivity. Then comes the psychoanalytic theories, and this says that these theories are summarized for the Freud that you can understand obsessional symptoms. Freud, as per Freud, he says that it comes from the unconscious impulses of an aggressive or sexual nature. This I am telling you, Freud is very clear of one thing, that the pillars of personality can be two. One is that we are very much driven by the aggression. Okay, two things basically drives us. One is aggression and one is the libido, which is the sexual urge. So if we are controlling the aggression and libido, then it is fine. Then it is healthy personality. But then many a times we are not being able to balance the libido and the aggression, and sometimes this is a heightened functionality or it is a very less, so hyper or hypo. So when there is this a lot of functionality happening, or maybe it is not happening at all, this leads to a lot of problems, out of which one of them is definitely the obsessive and compulsive disorder. Okay, and this idea reflects that aggressive and sexual fantasies of many obsessional patients, and with their restraints on their own aggressive and sexual impulses. So there is a lot of problem on this, and Freud has proposed, if you have if I think you know that he has also said about the psychosexual stages, where it starts from oral stage, then anal stage, right? You have heard about this. So Freud proposed that obsessional symptoms occur when there is a regression মানে ওটা কিন্তু ডিফেন্স, regression মানে going back to an earlier happy stage of life, and that happy stage of life for these people is the anal stage. Anal stage হয়তো অনেক বড়, কিন্তু anal স্টেজটা 2 বছরের মতন বয়স যখন তখন হয়, যেখানে তোমার pleasure erogenous zoneটা is the anus, and this is exactly that place where the person is given toilet training. Am I clear? So যখন when this thing keeps on happening, the person basically is very much, you know, regressing to the anal stage of development, and this is a way to avoid impulses relating to the genital and the Oedipal stages. ঠিক আছে, genital and the Oedipal stages এর জায়গাটা the person avoids, and that is why this it is reflected in the obsessional thoughts. And then again you have the causes related to learning also, that obsessional rituals are a form of avoidance response. The learning theorists will say the obsessional rituals are a form of avoidance response. Then coming to the cognitive explanation, they will say that people with obsessional disorder respond to such thoughts as if they were personally responsible for their consequences. So they actually are having a lot of negative thoughts, and which leads to the errors of thinking. And the errors of thinking are like, it can be maximization, it can be minimization, it can be personalization. Everything you're taking so very personally, and selective abstraction and overgeneralization. So these are the errors of thought, errors of the thinking process which happens. And then when these are happening, then it is very difficult for you not to be in a whirlpool of intrusive thoughts, and you will be kind of helpless. You will not be able to come out of this particular thinking whatever activity which you're going in or you're being in, right? And treatment, again the same type of treatment for OCD. You have medication. Okay, and I told you here that 5-HT যদি প্রবলেম হয় তাহলে একটা ওষুধ আছে যেটা হচ্ছে ক্লোমিপ্রামাইন। ওকে, ওটা যেরকম ফ্লুভোজামাইন বলেছিলাম ফর ফোবিয়া, এখানে ক্লোমিপ্রামাইন আছে, ঠিক আছে, which is a tricyclic antidepressant. So sometimes this tricyclic antidepressant drug is required to actually block the effect of the 5-HT. ঠিক আছে, এটা একটা। আরেকটা তো SSRI আছে যেটা I told you, the specific serotonin reuptake. So all these are a part of the pharmacotherapy, তাই তো, pharmacotherapy with drugs. But apart from this, and anti-anxiolytic drugs ও আছে। Apart from this, yes, behavior therapy, cognitive therapy, where you're explaining the person that nothing is wrong, like anything of that sort. Then you can go sometimes for a neurosurgery, which is a psychosurgery, because if you're having certain problems in the brain, if that surgery can help, তাহলে সেটা হতে পারে। Or it can be certain types of dynamic psychotherapy, where it is you're exploring, you're interpreting that whatever the person is basically having. Okay, why this painful thing, why there is an unproductive rumination. So that way you are dealing with one thought one after the other and try to understand. And yes, relaxation and exercises, all this, the very much it's there, but it is very important to know the patient, what is the need of the patient. And many a times, the choice of the treatment, that choice of treatment is basically depending on the person's intelligence and the personality. Okay, তাহলে the choice of the treatment depends on that. And it is very important because সবাইকার তো সব ট্রিটমেন্ট কিন্তু চলে না, তাই তো, সবাইকার সব ওষুধও যেরকম চলে না, সবাইকার সব ট্রিটমেন্টও চলে না। তো সেরকম ভাবে তোমাকে ডিসাইড করতে হবে কি কোন ট্রিটমেন্টটা কার জন্য বেটার। সেটাও ডিপেন্ড করছে তার সার্কামস্টান্সেস ওপর, কোথায় সে থাকছে কিরাম, ঠিক আছে। তিনটে আমাদের মেজর অ্যাংজাইটি ডিসঅর্ডার্স আর ডান। Now we will do PTSD. PTSD টা যেটা I told you, it is stress disorder, post traumatic. তার মানে there is a stressor which has been operating, yes, but whenever this stressor, আজকে কিন্তু I am no one to actually put you in that stress purposefully. I cannot. That stressor is there. Stressor is very much there as a in a natural way. So post the trauma, like that stressor can be a natural calamity. The stressor can be the stressor of a COVID-19. Okay, this coronavirus, we don't know how to face, how to deal with it, and how, and it came and all that, and it just got, our lives got just affected totally. So here I am not placing the person in a stressful situation. The person is actually in a stressful situation for whichever reason, like it can be this thing, a natural calamity, it can be unemployment, it can be the trauma of rape. এটা খুব মন দিয়ে listen, okay, this is very important. It can be a trauma of rape, it can be unemployment, it can be being held hostage, you're being kidnapped. তো সেটারও তো একটা a lot of stress operates. If you are getting kidnapped, then a lot of stress is operating. You don't know whether you will be having that relief or not. Will you be left free? All this you don't know. So you are very much scared, okay, that what will happen, you might just die. So this is there. Then it is bereavement. That is someone's death, okay, of a very closed person in your family, death of a very closed person in the family, and that is bereavement. Then what you have next is, next one, which is, suppose we can say that I've already told you about this, that is the trauma of rape, and this is also something not very pleasant. Okay, so how to take that and how the person is feeling extremely guilty, all this will be there. Then it is about the mm, military combat. Okay, suppose certain emergency conditions are declared, and then you are in a state, you're fixed that you don't know, there is terror attacks and there is a world war, and you don't know how to come out of it. So all these situations, এতগুলো যে example I gave you just now, okay, starting from unemployment to poverty to rape to military combat to natural calamities to military, this thing, being held hostage, okay, then loss of pet, এই এত, এটা তো তোমার নিজের কিছু তো করার নেই, it is just happening to you and it happened. And also one more is price rise and inflation, so there, which is a lot of economic crisis. So when these things are happening, okay, how you are basically taking it and post the situation, তাই জন্য post trauma, এগুলো তো it is basically causing a trauma to you. যখন তোমাকে, the person has raped you, after that, that is the post that activity, post the rape which has been, on you, you know how are you feeling, সেই জায়গাটা post, once that particular situation is over and you are no one to make the situation occur or happen. Your thing is just that you are concerned that whenever something of these, whatever examples I gave you, occurs, then what happens? Then definitely the person is in a lot of stress, and that does it lead to a disorder? And here the answer is yes, it leads to a disorder. And that is why, because because we are appraising the stressor as very threatening, and it's a natural reaction. There will be arousal, the autonomic hyperactivity will be there, the autonomic nervous system will function very fast. So when we appraise a stressor as threatening, a natural reaction is arousal and there is a fear. Okay, and as we have seen that this emotional factors and the cognitive factors, all these basically, and the physical factors, all these basically shape our mind. Okay, and says that okay, fine, then this is a stressor operating. So physically, like for example, physically our changes gulo hote থাকে, like physically we perspire, we have palpitation, our breathing becomes very fast, there is muscle tension, the heart beats faster, okay, we turn pale, we develop goosebumps, all these things happen. And emotional response kiram hoy, like suppose we are kind of getting very threatened, there is a horror, there is dread, there is even panic. Okay, so all these things are happening. Now when these are there, it is by the DSM, they have said that this is a disorder, and now they have labeled this as a post-traumatic stress disorder, and it technically lists these patterns as anxiety disorder, but factors, or there are symptoms also. Each and every of these classifications have certain symptoms attached to it. Okay, and there is a psychophysiological disturbance. Okay, there are disturbances also. The psychological and physical stress disorders, there are problems which are associated with your real life. Okay, and why we are talking about the autonomic nervous system? Because the sympathetic and the parasympathetic which are there, basically the it works antagonistically. It works in the opposite way. Okay, so what happens is that in extensive, when there's a lot of network of fibers, it is there. Okay, and then it gets a trigger when the person is in a stressful situation, And the autonomic nervous system, the network of the fibers, nerve fibers that are connecting the CNS to all the other organs of the body. And it is also responsible to regulate the involuntary activities, and which are very important. What are those? Those are breathing, those are heartbeat management, then blood pressure and perspiration, okay, and all these. And definitely the endocrine system, so very much it is there, all the endocrine glands, which is releasing the hormone directly to the bloodstream. So এই যে পুরো জিনিসটা, basically this is how stress and arousal is happening, and how the flight and fight responses are taking place. Okay, now when the perceived danger is passing, a group of the autonomic nervous system called the parasympathetic part basically helps you to return to that calm state. Our sympathetic gets innervated when you are facing stress. So when we are facing the stressful situation, the sympathetic division of the nervous system gets innervated. And when we want to relax, when the stressor has finally gone away, then it is the parasympathetic division that works. And together the sympathetic as well as the parasympathetic nervous system, it helps control our arousal. Okay, this is important. It helps to control our arousal, our fear reactions, and they enable our body to function reliably across all kinds of situations. Have you understood? So it helps us to function that way reliably. And we cannot forget one thing, one axis basically, which is the HPA, hypothalamic pituitary adrenal pathway. So hypothalamus, it is a part of the diencephalon, okay? And pituitary gland is the master gland, because the other glands are controlled by the pituitary gland, and it is located at the base of the neck. And we have the adrenal cortex and adrenal medulla is there, which is basically my adrenal glands is located near the kidneys. So this pathway, the hypothalamic pituitary adrenal HPA যে pathwayটা আছে, so when we are confronted by the stressors, what happens is the hypothalamus also signals the pituitary gland, okay, and that lies nearby to secrete the ACTH. You know the full form of ACTH? Adrenocorticotropic hormone. Okay, and what happens is sometimes this is only called the body's major stress hormone. This is very important. I can repeat it once more. The hypothalamic pituitary adrenal pathway, which is the HPA pathway, what happens is when we are confronted with the stressors, when we face the stressors, the hypothalamus signals the pituitary gland, okay, and which is basically lying very nearby to secrete the ACTH, and sometimes the layer of the adrenal glands. And this is actually called the stress hormone, major stress hormone. Our ACTH ki kore, it stimulates the outer layer of the adrenal glands. It stimulates the outer layer, and which is actually known as the adrenal cortex. And this adrenal cortex releases a group of hormones which are the stress hormones, and it is known as corticosteroids. Basically from the hormone cortisol. Corticosteroids release করে. So when these corticosteroids travel to the body organs, then wherever they are, further they generate this arousal and fear reactions, and therefore eventually what happens, the cortisoids signal the hippocampus. Hippocampus is a part of the basically the limbic system. Okay, limbic system has hippocampus, it has amygdala and septum, apart from some other organs, but the hippocampus gets signal. And the brain, it is that part of the brain that seems to control the emotional memories. And this hippocampus helps the body to turn off the arousal. So this is a long process. You have to be very thorough, and it is basically important. Okay, very important for this PTSD. And whenever this happens, basically we either engage in a flight response or a fight response. We avoid or face the situation. Okay, so this one, there can be basically দুটো stress disorder আছে তোমার PTSD syllabus এ আছে বলে I mentioned, but basically there is also one more which is the acute stress disorder. So if we want to discuss about certain checklist which is given by the DSM for PTSD, there is should be an history of having experienced a or confronted either death, serious injury, threat of a physical integrity of the self on also of others. You should মানে এগুলো তোমাকে ফেস করতে হবে, নাহলে তো আর পোস্ট ট্রমাটিকটা হচ্ছে না, তাই না? তো এটা ফেস করতে হবে। And then there is a reaction of intense fear, there is helplessness, there is horror. Okay, horror. And these persistently there is a re-experience in at least one of the following ways. So you have to মানে একবার experience হলো তারপর আর হলো না, সেটা is not good enough to rule that you are not in a perfect kind of a state. এটা নয়, it's not good enough to rule. So সেখানে you have to be kind of experiencing it again and again. One is recurrent distressing recollections. কিছু এমন একটা recollection করছো যেটাতে you are becoming sad again and again. Then there is distressing dreams, there is illusions, there is flashbacks. Okay, this is a distressing one. Then there is a distress which is caused by the reminders of the event. Okay, এটা একটা আছে। আরেকটা হচ্ছে যে there is a persistent avoidance of detachment, a subjective sense of numbing, মানে একটা numb sensation হয়ে যাচ্ছে। তারপরে হচ্ছে it can be certain traumatic, okay, traumatic or emotional unresponsiveness. আরেকটা, you should have at least these two of these symptoms. One is difficulty sleeping, irritability, poor concentration, hypervigilance মানে being excessively alert, আর exaggerated startled response, হঠাৎ করে you're getting surprised and shocked. That's the startled response. So out of this 5 or 6, minimum 2 you should be having. So this is what is the PTSD. But PTSD, again, I'm telling you, the different causes or the types can be one, it can be the combat, okay, which generally আগে কার দিনে বলা হতো shell shock. Shell shock, people used to age a world war, there were death one after the other, people were dying, right? So this shell shock basically made people get numb. They just didn't know there was so much of explosions happening. People were dying at a mass scale. Imagine, মানে একটা example আমি তোমাকে বলছি, Vietnam War. Okay, we have so many movies also on this, right? Vietnam War এর উপর. And then you can see how the people are actually seeing what is happening, what type of torture which is there, right? And I mean, I'm not very good with the names of the movies, but I've seen that. মানে একটা ধরো ট্রাকে করে নিয়ে আসলো, নিয়ে এসে ছেলে, woman and it is children, and women and children are straight away killed because they are thinking that no, women and children দিয়ে কিছু তো হবে না, we want people যে আমাদের help করতে পারবে, and then it can be the men, and those men who are not good enough তাকেও মেরে দাও, straight away at gunpoint they were being killed. So if you're witnessing that, so you can imagine the amount of trauma which you're having. Okay, then any kind of like sexual assault, like I told you, rape, which is a forced sexual intercourse, and that is something which you're not very happy about. Okay, and there is a psychological impact of the rape. Rape victims typically experience enormous distress and guilt. Okay, and there is also a lot of self-blame, the depression is there, suspiciousness is there, they are anxious, they feel that something is wrong with them, there is guilt, there is sexual dysfunction. So many things are there apart from the physical pain. Okay, then the post-traumatic trauma from the terrorist attack. Can we all just for half a second think and get, close our eyes and think about the 26/11 attack? Just think, just giving a half a second pause. 26/11 attack, and think you were one of the survivors at Taj Hotel or the Trident or the station, VT station. Just think. And then you can imagine that more gele to alada kotha, you are dying. But when you are basically, witnessing that and you're living, you're witnessing that and you're living. So you can imagine what is the pain. Now I think we'll all understand, right? What is exactly what that happens when you're having a PTSD. Something very, very important. PTSD. So here, whenever there and it is just not, like whether you will survive or not. Yes, I accept that is the case also. Whether you think that whether you're surviving or you're not surviving, that thing is very much there. At the same time, what is that is there inside your head? That there are so many people who are dying, so I will be the next one. Okay, so you're seeing, and then you just start, you get scared. আর এখানে তো this is not unreasonable. This is very much reasonable. Am I clear? It is very much reasonable. And you start getting scared and you really don't know what to do. So these things are there, right? So it's a terrorism holo. Then I've already told you about there are Holocaust, there are people who are survivors of the Holocaust, right? And then and there are a lot of researches. I want you to look up to all these researches. Then certain people, there is a severity of the childhood trauma. We cannot forget the childhood abuses. These childhood abuses can be emotional, it can be physical abuse, it can be physical মানে মারছে, emotional to you understand, sexual, okay, different types of abuses are there. So those who have very adverse childhood, they also can have a PTSD. Parents are separated, divorced, they are brought up by someone else, so it's more of a they have shown pity. Okay, the lack of social support is very important again. Okay, and because you are, like for example, the rape victims, if they're having the social support, then they still feel loved, cared and valued and accepted by others. But then when they're not having this, then definitely it's a lot more difficult for them to accept themselves. Okay, so I hope you have understood the PTSD also. I mean, lot of diseases you might just get a bit confused, but then four of them are done. Basically it's not four because there are types also. Phobia, it had types, because the questions can also come like that. Okay, so phobia te তোমার কিন্তু আলাদা করে simple phobia can come, which is also known as specific phobia. Social phobia can come, and agoraphobia. ঠিক আছে, the questions can come like that. Then the GAD, it's okay. OCD also, it's okay. PTSD, again, all the different causes and the types I told you. And finally, how do the clinicians, they try to manage people with this PTSD? And we now take up, I think, one last of it, one will still remain, and we will carry forward to our next class, which is on 11. Do I have a class with you on 11? I think yes. Anyone, just unmute yourself and say anyone. Amreen, Mumtaz. Amreen, do you have a class on 11?
Yes, ma'am. Yes, ma'am. We
Yes.
have class on 11.
Yeah, 11, at 11 o'clock again. The same. Today, actually, the link was given for me on 11th. Okay. So I took 10 minutes,
Yes,
so like
ma'am.
I said, and I was waiting for today's class link. And that is how I got a bit delayed. But anyways, it's okay. Amreen, you can unmute yourself. Okay. So
Okay, ma'am. Thank you.
we will carry forward another 10-15 minutes now. I will do one more with you today. It's getting little heavy, I know, because it's not easy. Okay, 2 hours we can just do phobia and OCD because it's quite huge. So we will do somatoform today. Okay, or maybe we can do dissociative because somatoform ta arektu boro. Somatoform and this childhood one which is left, we start our class with that only on Friday. That's Friday, I think 11th is Friday. And then we go to the block 3. Okay, so block 3 টা আমাদের করতে হবে। এত বড় না, এত তাড়াতাড়ি তাড়াতাড়ি you can't manage. Okay, then we will speak about dissociative. What is dissociation? Basically, it is disassociation. Dissociative disorder, we will say it is a disassociation. And somatoform and dissociative disorder is given together only in many of the books. So when we speak about a disassociation, basically there is a lack of association, okay, where I am not being able to relate. So here I'm just telling you, just listen to this very carefully. Many of us, we have experienced, so there is a sense of wholeness, okay, or continuity as we interact with the world. Now, when we perceive ourselves as being a more, than a random collection of isolated sensory experiences, like we don't know what is basically happening, we cannot understand our feelings and behaviors, and we cannot relate it to our identity. If things are happening like that, our action, we are very clear that this is my identity, this is what defines me, I have a very clear sense of who we are, and which is very unique to our preferences, our abilities, because what you prefer and what I am preferring, that is not the, it is not same, it is different. So সেই জায়গাটায় I should be knowing that what is that defines me. But যখন the moment you are very much in a fix, you are getting very unclear and vague of your identity, of your expectations, of your values, of your goals, then there is a feeling that we are no more being able to be aware of our existence. We are not being able to be aware of who we are. Do you understand? When my identity gets shaken, so when this identity is getting shaken and we actually don't know that who we are and what we want to do, then it's a very big problem, and where we say there is disassociation. And memory is the key thing here. Memory is a key thing to why, because see, memory is actually helping you to feel the wholeness and understand and feel your identity and relate it to the continuums of past, present, and future. So, our recall of the past experiences, although not always, it is not always accurate. But whatever past experiences we have recall, that is হতেও তো পারে that every time it is not accurate, and that determines how we react to the present events. Okay, so that is why এখন সবাই বলে না that we should practice mindfulness. Okay, you should know how to be mindful every day. So basically here comes in mindfulness also, because mindfulness is living in the present, okay, present, than the past or the future. So you have to know, you have to acknowledge yourself right now what it is, and when this only gets very disrupted, this only gets very hodgepodge, can you understand that what is the problem? It becomes very very difficult, it becomes very demanding. Am I clear? So now what happens in dissociative disorder is, there are major changes in the memory, and that do not have a clear physical cause. Okay, major changes in memory, your identity gets disrupted, you are no more being able to relate it to your consciousness, and the past, present, future, it's all very unclear what is happening. Okay, and in such disorders, the person's memory typically seems to be disassociated or separated from the rest. So this is what you understand and what is the meaning of dissociative disorder. But dissociative disorder are further classified under 3 headings. First is dissociative amnesia. Then it is dissociative fugue. অনেক সময় অনেক বইতে you will see amnesia and fugue written together. So what is amnesia? Amnesia is forgetting, right? So what happens in dissociative amnesia? Dissociative amnesia, one or more episodes of inability to recall important personal information, usually which is of a traumatic and a stressful nature. Okay, and there is too extensive, when it is very much too extensive to be explained by ordinary forgetfulness. So it is not an ordinary forgetfulness at all. You are forgetting many things, and that is creating distress and dysfunction. That is your dissociative amnesia. You just forget who you are, what are you doing, সবকিছু you forget, right? So that is the, and there are many you can, and এটা can be a partial amnesia, selective one in nature, and it can be a very generalized amnesia also. So dissociative amnesia may be localized, it can be selective, it can be generalized, or it can also be a continuous amnesia. Amnesia means forgetting. Now what is fugue? Fugue is when you actually forget everything, that is why it is associated with amnesia, and you start a having a new identity of your own. Basically, when I forget who am I forget my identity, and take when I start staying somewhere, I just take up a new identity altogether. Maybe a new name, maybe a new kind of people who are related to me. So all these things come up. Okay, so this is fugue. Fugue is like unexpected travel from home. So when the fugue is there, you just leave home and you just go so far away, and you forget to amnesia সাথেই তো হয়েছে, and you just take up a totally new identity. Okay, and you go away from your home, you go away from your workplace, and you're just totally unable to recall your past. Okay, and there is confusion about your personal identity, and there is an even an assumption of a new identity. I told you, you just start living with, you take up a new identity and you start living with it. Okay, if even if you are married, you forgot that you are married and you might just marry all over again. And yes, this also causes significant distress and impairment. So you have dissociative amnesia, you have dissociative fugue, then you have something called আরো দুটো আছে, একটা হচ্ছে DID, dissociative identity disorder, which was earlier known as multiple personality disorder. And I think you also know that this has been given অনেকবার কিন্তু ইয়েতে তোমার movies, books, books and movies, both Hollywood and Bollywood movies. Okay, they have shown a lot of movies are there with this multiple personality disorder. Okay, now what happens here? There is one, this I think many of you know because this is very interesting in the এত movie আর সব হয়েছে. One person, there are many personalities in one person. Okay, and one of the personality is a host personality, host, and the other personalities, there are my Dr. Jekyll and Mr. Hyde এর মতন, right? So what happens is the person, one personality he or she has যেটা কি আছে যেটা রিয়ালিটিতে, and he develops a lot of altered personalities, and এই যে altered personalities গুলো আছে, these are based from fantasies basically. Okay, and all these altered personality is regarding certain things which you aspire to live, which you have not left, but you aspire to be like that, you aspire to live like that, but you are yet to do many things, you don't know. ঠিক আছে, that generally the altered personalities are not matching with your real personality. Real personality, if you're very timid, altered personality, you want to be very strong headed and you want to take decisions, you want to be very spontaneous. Okay, so এগুলো হয়ে গেল altered, which you aspire to be, ওই ideal self এর মতন. So and a person can have many altered personalities. The person and this altered personalities can oscillate, oscillation হতে পারে একবার এটা একবার ওটা একবার এটা একবার এটা, you can come back to one altered personality, or you might not come back to any of the altered personality ever, এরমও হতে পারে, so there can be a lot of permutation combination. So here for NPD, the presence of two or more distinct identities or personality states are there. The control of the person's behavior recurrently taken by at least one of these identities. So our personality states, now here one of my identity is such like that drives my personality. Now when the other identity comes, then that becomes more focused. Then the other one which was there previously, that becomes very dormant. So it keeps on happening like that. And there is an inability to recall. Okay, inability to recall important personal information that is too extensive to be explained by others' forgetfulness. Am I clear? So there is an inability, you can't even recall. That is why you are not knowing, oh, was that me? You will totally deny, because তোমার তো consciousness নেই যে তুমি ওটা. Okay, the Jekyll and Hyde, they don't know that they are only these two people, the same person. So সেখানে inability to recall that particular information, okay, personal information that is too extensive to be explained by ordinary forgetfulness. So this is there, multiple personality. Our dissociative fugue, which I have told you, all this can also be witnessed during the military combat. Okay, military combat, you can there are a lot of studies which you can read, and you will read also about the altered personalities, and the which is also altered personality is also known as sub personalities, basically sub personality. And there is a transition or a switching from the host to the altered. Okay, host to the alter, there is always a switching. And there were cases of multiple personality disorder which were reported long time back. কবে থেকে it has started from the like 3 centuries ago, তখন থেকে it has started. Okay, almost 3 centuries ago. And there are a lot of, that American Psychological Association treatments on it, because it is quite challenging. It's not very easy to deal with a DID patient. So a person having DID, because it is also very dangerous, because oh, jane na, he does not remember only that it is him. And most cases are first diagnosed in the late adolescence. A multiple personality disorder is mainly diagnosed initially in the late adolescence or early adulthood. Okay, but the symptoms usually begin in early childhood. This you should remember. And basically 97, almost 97 of the percent অনেক সময় বলে যে these patients have been physically, often sexually abused during the early years. This is one of the causes also. And women receive this diagnosis at least 3 times as often as men. Okay, this is also a thing which was done by the APA. So the women, they receive the diagnosis at least 3 times as often as men. And in some cases, the parents, of people with multiple personality appear to have displayed some kind of dissociative disorder. এটাও আছে, the parent থেকে চাইলেও কিন্তু it might come. Okay, and then the last one is the dissociative identity disorder. তার মানে first হচ্ছে dissociative amnesia, dissociative fugue, DID, which is also known as MPD, and the last one is depersonalization. Okay, depersonalization. এখানে suppose if I tell you that there is a picture, okay, just try to understand. There is a picture drawn where one person, like suppose you are seeing from a window, okay, upstairs, maybe 4-story building or 3-story building. You are looking on at a road where a lot of people are walking. সবাই পেছন দিক দিয়ে, you can see their head and the dress backside. Okay, you are seeing that everyone is like colored. Okay, and one person is black and white. basically that person who is black and white is having the depersonalization disorder. What does this explanation suggest? It suggests that this person, একটাই person, black and white, সবাই color. So it is a very contrast, number one. Number two, there is very clear sense of alienation. The person, that black and white person, is not being able to relate himself or herself with anyone who is present in the crowd. So you feel a very much like an alien. Suppose we go to Mars, or there is someone from Jupiter coming here, something of that sort. Kiram hobe, alien hobe. The person cannot actually match up with anyone who is around. And this is exactly the feeling when you have the depersonalization feeling, or the type under the dissociation. So you can understand that whether it be amnesia, or whether it be fugue, whether it be multiple personality disorder, or it can be depersonalization, everywhere the common thing is what? The common thing is disassociation. The common, and here self hypnosis helps a lot. This is a treatment, self hypnosis. So self hypnosis, where the process of hypnotizing oneself, sometimes the purpose of forgetting the unpleasant events. So here you want to just forget the unpleasant events, and then you undergo a self hypnosis. Okay, so hypnotic therapy, যেটা আমরা অন্যটা আগে ডিসকাস করে নিই, so hypnotherapy actually helps in dealing with the dissociative disorders. Okay, and yes, some kind of anxiety drugs তো আছেই যেটা হেল্প করতে পারে. Then you have to make the memory fine. এখানে তো এটাই, I have to make the memory fine. That is a challenge. You have to help in the fusion of the super personalities, integrating, merging of two or more sub personalities. সেখানে তুমি সুপার পার্সোনালিটি বানাও, সেই জায়গাটা একটা মানুষকে ডিআইডি তে you have to make the person understand that no, whatever these other things are happening, it is all you. You're the one who is doing, you have done this. So এই যে ব্যাপারটা, it is something very important for someone to realize that it is all me. And finally, the depersonalization, where it's a disorder marked by persistent and recurrent feeling of being detached from one's own mental process or body. So you're feeling very detached from your mental process or body. So you need to basically come back, you know, you need to be very much focused. এখানে বাচ্চারাও যখন এটা হয়, developing the, you have to develop the capacity of becoming self aware. So self awareness is very important, where such transient feelings will not happen. You know, you will not feel that, oh my god, my detachment is there, I cannot link myself anyone with people who are around me. Okay, so in a nutshell, how can I just conclude about the dissociative disorders like amnesia, fugue, maybe may end, may be treated, and also to that extent MPD with psychodynamic therapy, hypnotherapy, so and then medicines like sodium amobarbital, okay, that is a medicine that it's used. And then also there are, you know, basically developing self insight, self awareness. These are the things you can use. Okay, and sometimes একটা জিনিস বলে দিই যে these depersonalization disorder যাদের আছে, who feels very detached from their own mental process or body, they might also experience a derealization. So there is also a derealization which is there. Okay, derealization, but then we need to work with these very strongly, so that people are not in that deep dissociative mode, because that is something very scary and it can be detrimental for the person's existence. So we are left with only one from block 2, and that is the somatoform. সেটা এমনিতেও দুটো একসাথে করলে এমনিতেও গোলাতো, dissociative and somatoform টা. So till Friday, or rather Thursday, you just take in, try to absorb whatever we have done today: phobia, GAD, PTSD, and dissociative. And so next class on the 11th, we will be finishing first the somatoform, then the childhood mental disorder, which is autism and all, and then we start with block 3. So thank you students for your kind hearing. Okay, and study well. And yeah, I will then, what I'll do is, because anyways today is quite late, and the same thing I'm going to anyways do next day also, I can give you the books, the name of the books, or one book I can write it right now if you want, that I want you to buy. বিকজ দেখো একটা জিনিস আমি বলছি, সেটা হচ্ছে অ্যাবনর্মাল সাইকোলজি অনেকগুলো এডিশন আছে তো, লাইক আই টোল্ড ইউ কার্সন বুচার মিনেকা অ্যান্ড হুলি. Carson, Butcher, Mineka, Huli is the four names are there in the 13th edition. But when you go to the 16th or the 15th edition, one of the author might change and a new author might come. তাতে কোনো প্রবলেম নেই. It is okay. That much is acceptable. So ACTA, you can just go Oxford. I'm just putting it on the in the chat box. Oxford Book of Psychiatry. Okay, because this I think is available also. Oxford Book of Psychiatry by Gelder and Routh, Routh. Okay, Gelder, Routh. This I remember the two names. And then you have the abnormal psychology. The name is only that. Okay, textbook of abnormal psychology. You can have another one which is Saracen. Shetaও আছে. Many books are there. Okay, abnormal psychology, and it is Carson, Carson. Carson. Then you have Butcher, Butcher, and Mineka. I'm just writing the three names. This is there, and Huli. This is in the 13th edition. I have given you, this is in the 13th edition. Have you understood? So, but now, right now, it is very much there, the 16th edition has come. So, one of the names might just change. So, that is okay. Whichever you can just get hold of, you can use. So, thank you, students, so much. I will be seeing you again for seeing you virtually, whatever, on the 11th. Okay. Yeah.
Thank you so much, ma'am.
Thank you
Thank
so much,
you.
sir, ma'am.
Thank you.
Thank you,
You all
ma'am.
must be very hungry, so rush for your lunch.
Okay,
Yeah.
ma'am.
Okay. Bye.
Thank you.
Bye.
Thank you, ma'am.
Yeah.
Bye.
Thank you, ma'am.
Thank you, ma'am.
That's it.